I welcome everyone and thank you for joining this session on health. My name is Dileep Birur and I'm a manager at KPMG USA. Zhan Wang from the Center for Global Trade Analysis at Purdue University. He's hosting this session and also is recording today's session, and he will help to ensure keep us on allotted time. Before getting to the presentations, please allow me to remind everyone of the following session protocol and etiquette so that the session runs smoothly. All attendees except the person currently speaking, please keep the microphones muted. Unless otherwise noted, presentations will last for 20 minutes. The session host will verbally prompt the presenter when there are 2 minutes remaining of their allotted time. Discussion periods will last for 10 minutes after each presentation immediately. It's preferable for questions or comments to be entered in the chat. However, participants can raise their virtual hands as well. And I will monitor the chat and the participant list for raised hands during the discussion period and read the chat entries aloud for the presenter to respond verbally. During this session, we will hear 3 presenters today. And without further ado, please allow me to introduce our first speaker, Ms. Ghada El-Husseiny. She's an assistant lecturer at German University in Cairo, Egypt. She would be presenting on towards a donut economy, an institutional failure perspective. The floor is yours, Ghada.
Hi, thank you all. Before beginning, I'd just like to tell you how honored I am to be among you all, and it's truly a pleasure for me to present in the GTAP conference. So I'm Ghada El-Husseiny, and I'll be presenting my master's topic named Towards a Donut Economy and Institutional Failure Perspective. The presentation structure will be as follows. We'll start with an introduction, materials and method, then move to the theory and calculation, results and discussion, and then we will conclude, provide some policy implications, future research, and some limitations. So ever since the emergence of the COVID-19 pandemic, all 17 sustainable development goals have taken a massive hit. This pandemic has set off an urgent need to start focusing on the SDGs and to start questioning the efficiency of public spending, especially in the health and education sectors. So while it's widely known that there are market failures in social services, which requires government intervention in these services, and that breeds corruption, our purpose here is to actually measure the effect of this corruption on those publicly provided services and hence development outcomes. So according to the literature, we can actually better understand development failures if we are able to understand the effect of corruption. So this paper actually, this is the aim of this paper, is to measure the relationship between institutional failure measured by the level of corruption and the publicly provided services, especially in the health and education sectors. So we come up with 5 research questions that this paper aims to answer. The first is, what is the impact of corruption on education and health spending in both clusters, corrupt and clean countries? Second, what is the impact of education and health spending on education and health outcomes? And third, what is the impact of corruption on the effectiveness of education and health spending? Fourth, what is the impact of corruption on education and health outcomes directly? And last, what is the impact of corruption on the efficiency of education and health spending? So what exactly is the donut economy? This concept was designed by Kate Raworth in 2012. It's actually a compass for human welfare in which the middle part represents basic human deprivations such as water, food, shelter, etc. And the outer ring is actually the Earth's boundaries. And both boundaries are more or less incorporated in the Sustainable Development Goals put out by the United Nations. So moving to our materials and methods, this paper draws data for 22 clean and 22 corrupt countries. We use a regression analysis, once using the pooled OLS, once using the fixed effects model. Our statistical software package is Stata MP13. And listed here is our dependent variables and key explanatory variables. We also argue to include economic, socioeconomic, and demographic as contributing variables. So the Grossman model can actually be used as a basis for this paper. The model argues that human beings are endowed with health, which is, according to the model, a capital stock. And as time passes, this capital stock depreciates and requires investment. And one way to invest in it is through health expenditures. So starting with our results, so the first two equations actually denote the education sector. The second two equations denote the health sector. And the first one denotes the pooled OLS results, and the second one denotes the fixed effects. So starting with our first model, the effect of corruption on education and health spending, we find out that corruption has a positive and significant effect on health expenditure in both clusters, clean and corrupt countries, and positive and significant effect on education expenditure in clean countries. The only insignificant effect was the effect of corruption on education expenditures in our corrupt clusters. Now, this actually, one might think, why would corrupt countries have an insignificant effect? And why didn't it show in our clean cluster, since by definition, clean countries are non-corrupt? These results actually make perfect sense since corruption targets oligopolistic markets with high-tech products and low price transparency. So actually the education sector poses as an unattractive sector for corrupt practices due to its minimum rent-seeking opportunities. We run the same model using the fixed effects model, and we find out that corruption loses its significance in all four specifications. This indicates that the way countries determine health and education expenditures is completely country-specific, and corruption actually has a minimum role. And at last, we calculate the Akayiki information criterion to test for the relative quality of statistical models, and we find out that the fixed effects model is actually more fit. So moving to our second model is the effect of education and health spending on education and health outcomes. Again, the first one denotes the pooled OLS, while the second one denotes the fixed effects. So what we find out here is that education expenditure has a positive and significant effect on school enrollment rates in both clusters, corrupt and clean countries, while health expenditures has a negative and significant effect on infant mortality rates, again, on both clusters. However, we can see here clearly that education expenditures has a very similar effect to school enrollment rates on in corrupt and clean countries. This is because school enrollment rates is merely a quantitative measure that doesn't capture the quality of education. You will find here that the school enrollment rates in corrupt countries actually increased. However, in terms of educational quality, the students might did not harvest any benefits. So we run the same model using the fixed effects model, and there were two major changes. The first change is that health expenditure is now, the effect of health expenditure on infant mortality rates in corrupt countries is now actually positive and significant. Why would health expenditures increase infant mortality rates in corrupt countries? This is actually the effect of our clustering. Because of the corrupt nature of these countries, we would expect that all health expenditures that are put into this sector completely evaporates and goes to waste. And these results actually coincide with Hauner and Kayobi 2008, who argue with increasing expenditures, citizens might actually have a declining marginal benefit or no benefit at all. And in our case, actually increasing expenditures left citizens worse off. The second abnormal result here is that the education expenditure now has a negative effect on school enrollment rates in our clean cluster. Why did it show up negative and significant? This is because of actually two things. The first, school enrollment rates in our clean cluster has been going down, shown in this graph. And the education expenditures from the year 2005 till 2015 has been going down in developed nations. So we would expect with more or less constant school enrollment rates and declining expenditures to see a negative coefficient. We actually, we also get the data on hospital beds for 17 out of our 22 clean countries, and we would actually find that hospital beds has also been decreasing. The declining nature of education and health expenditures in these countries is actually one of the main reasons why COVID-19 wasn't maintained immediately. So moving to our third model, what is the impact of corruption on the effectiveness of education and health spending in our clusters? So what we do here is we actually take our second model, the effect of spending on outcomes. And what we try to do here is test if those two coefficients, the education expenditure coefficients and the health expenditure coefficients, are actually statistically different from each other. Because due to these results, we can see that corrupt countries are actually more effective at improving infant mortality rates and school enrollment rates. So we actually conduct a simple z-test and follow the equation and procedures provided by Luong et al. We calculate the z-score and we calculate the 95% confidence interval. We do the exact same thing for the health sector. We calculate the z-scores and the 95% confidence interval. And we find that for the education sector, there is actually no statistical difference between the coefficients of education expenditure in both clusters. This indicates that corrupt countries do not necessarily have more effective education expenditures. However, in the health sector, there was a statistical difference between the two coefficients in health expenditures in both clusters. This indicates that corrupt countries do in fact have more effective health expenditure. This is actually quite weird that corrupt countries to have more effective health expenditures. However, we have three reasonings for this result. First, it's maybe because of the declining nature of health spending in developed nations. Third, the massive amount of foreign health aid that has been directed toward developing nations, especially after the emergence of the MDGs and the SDGs. And third, developed nations actually spend more on caring rather than curing services, and that is why there is no actually noticeable gains in outcomes. So moving to our fourth model, the effect of corruption on outcomes directly, we find out that corruption has a negative and significant effect on infant mortality rates in both clusters. However, corruption does not have any significance on school enrollment rates, again, in both clusters. This actually complements what we have been saying before, that the education sector poses as an unattractive sector for corrupt practices due to its small rent-seeking opportunities. We're on the same model using the fixed effects, and we find one major difference is that corruption now has a positive and significant effect on school enrollment rates. This could actually mean that corruption does play a role in improving educational outcomes if we take country-specific effects into account. And lastly, again, the fixed effect model proved to be statistically more fit than the pooled OLS based on the AIC or the Academic Information Criteria. So moving to our last model, the effect of corruption on the efficiency of health and education spending. So what we try to do here is we ask a hypothetical question. If corrupt countries were like clean countries in the way they treated health and education, what would be their potential spending be? And we calculate their actual spending, and the difference between their actual and potential spending is the efficiency gap. So the difference between the two equations is actually this coefficient. This beta 1 education 1 means the corruption coefficient for education expenditures in corrupt countries, while the second one is the beta coefficient for education expenditures in clean countries. And the efficiency gap is actually 1%. These results indicate that the efficiency between corrupt and clean countries with respect to education is not that big after all. We do the exact same thing for the health sector, and we find that the difference between, we find that the actual expenditures is actually 3.912, and their potential is 3.881 for corrupt countries. So we can actually observe here that corrupt countries, again, are more efficient than clean countries regarding the health sector. Again, this could be because healthcare spending in developed nations do not produce noticeable gains due to the fact that they spend more on caring rather than on curing services. So to conclude, this paper actually examines if corruption cripples our march towards the SDGs, and specifically SDG 3 and 4, health and education. We found out that the effect of corruption is actually more greatly felt in the health sector than in the education sector for both clusters. We found that the health and education expenditures are determined to a great extent on country-specific factors, again in both clusters. We found that health and education expenditures have a great impact on outcomes in both clusters. And lastly, health expenditures were actually more effective and efficient in corrupt countries. So what do we actually get out of this? Some policy implications. First, increasing spending will not bring forth great improvements in health sector in developed countries as it would in developing countries. Government should be very cautious when they use spending as an instrument, and they should put more emphasis on the quality of spending rather than on the quantity. We believe that if effective anti-corrupt policies packages were put in place in developing countries, there would be actually better development outcomes. And lastly, policies should tackle the accreditation, selection, employment, and compensation of teachers, and the health staff should be closely monitored to track their performance. So as for the limitations, the major limitation of this paper is it actually uses the CPI as a measure for corruption, which is a highly subjective measure and it's prone to individual biases. So for future research, it's actually advised to use a more objective measure of corruption. And lastly, corruption or corrupt countries on average had a more effective and efficient health expenditures, while some reasoning were provided to why these results prevail. We believe it should be further studied. Thank you.
Thank you, Ghada. That was a nice presentation. Now let's go ahead and take some questions from the audience. You can also enter any questions or comments in the chat. Yes, Zhan.
Yeah, thank you very much for the very nice presentation, and that is provide a lot of interesting implications and findings. So my question is that I wonder, when you consider the relation between the outcomes and the predictors, do you also consider to add some time lag? Because we know that if you have the increase in expenditure today, it may not influence the current situation, but it may have some influence on the situation maybe in the next 3 years, 5 years, 10 years. I think maybe if you can consider to having the time lag.
Sorry, the voice is unclear. Were you asking about the lags?
Yes, lag.
Time lag.
Yes, I actually tried to add the lags, but however, somehow they were not insignificant. We would expect that actually adding lags would be significant because corruption actually takes time to set its effect. However, when I tried to add some lags, they weren't actually very significant, so I removed the lags from the models.
Okay, yeah. So thanks for the clarification.
Thank you. Any other questions? If not, Ghada, oh yeah, Henning, please go ahead.
Okay, just a couple of small questions. So I wondered, a key part of your analysis seems to be based on the division of countries in your sample between corrupt and clean. And so I wondered if you've actually looked into, I mean, whether that sort of prior decision had any impact, or have you done some sensitivity analysis perhaps? And also I wondered if you've thought about your definition. I mean, you are talking about effectiveness and efficiency, and but you're sort of likening it to increased public spending is a good thing, and I'm just wondering, sometimes increased public spending may not necessarily be a good thing. So
yes, actually, this was one of the policy implications here, that we should not actually just spend money as a first political reflex, and we should start to put emphasis on the spending in terms of quality, not on the quantity, as increasing spending would actually not bring great improvements. The quality of spending should be improved, not the quantity. So, yeah. And yes, the clustering effect before doing the clustering effect, I thought that clustering them into groups would actually give me a better picture. And when clustering them, I actually chose the countries with the least CPI, countries with 30 and 40 maybe. And the clean countries, I chose the 80s and 90s for the CPI. To actually differentiate between the results, yes, I think the results might have greatly, this clustering effect might have greatly shown, especially the effect of corruption on the education sector, whether in corrupt or clean countries. And yes, the clustering effect did show great differences between the two countries.
Okay, thank you, Ghada. I have a couple of clarifications. You took 22 countries each, right? Each category. Yes. So did you pay attention to the size of the economies, or like what was the criteria?
No, that not really. Yes, there might be some countries who actually had bigger size, bigger populations, bigger spending. Yes, this is actually one of the major things that should be taken into consideration. However, when we did the whole point of doing the z-test is actually to measure if there is a statistical difference between the two coefficients, regardless of the size of the countries. Yes, but I do get your point. There are major differences between the size of the countries, the population, the spending. Yes.
Thank you. And this is beyond the paper, what you have presented. So if you relate it to the COVID time expenditure, so your data set included until 2017, let's consider what happened in the past 2 years in terms of education sector, that's the worst hit one, and also healthcare expenditure. So what do you think, like what would be the result if you want to fit a model for the last 2 years data?
I didn't include these data because for a lot of corrupt countries, sadly, the data was not was unavailable, especially for corrupt countries. However, we can take actually some implications. Like we have said, the clean countries have been decreasing expenditures on health. And this was actually, I believe this was actually one of the main reasons that COVID-19 was not actually maintained quickly for a lot of countries, clean, developed countries. And this is because evident from the results that health expenditures have been going down for a lot of time, for quite 10 years or 15 years. So, yeah. However, again, I did not include this period because of a lot of data. It wasn't available for the corrupt countries.
Yeah, many, I mean that the COVID packages data is available, but the thing is, yeah, many countries have like a lot of discrepancy in announcing those packages. Yes. Thank you so much. If others do not have any questions, so we can move. So let's please thank Ghada, and let's give her a round of applause for a nice presentation. Thank you, Ghada. Our next presenter is Ms. Trang Luong. She's a student at Montclair State University, where I used to work earlier. And she will be presenting on charting the global economic recovery from COVID-19 vaccinations. Ghada, if you could stop sharing the screen.
Oh, okay.
Oh, yeah, try it. Trang, could you, start sharing the screen? Yes. Yes, the floor is yours, Trang. Thank you.
Thank you for inviting me. My research is about tracking the global economic recovery from COVID-19 vaccination. My talk will be in several parts. In the first part, I'm going to talk about the impact of the COVID-19 on global economy. Then I would like to introduce the current status of vaccine equity. And next, the objective, modeling approach, and scenario will be explained. The key finding and conclusion will come at the end of my presentation. So since the COVID-19 outbreak in early 2020, the growth of the GDP declines about 4%, with the highest growth in Argentina 99%, Italy 89%, India 9%, Colombia 68%, and the USA 3.4%. while China and Vietnam experienced a slight increase of 2.3% and 2.9%. These two economies registered the positive economic growth because they took the early action ranging from border closure and face covering, massive testing and lockdown, contact tracing, and compulsory quarantines based on the possible exposure rather than the symptom only. And these strategies minimize the virus transmission in those two countries. So that's explain why the GDP still increased in the pandemic time. And according to the latest report of the International Labour Organization in 2020, in comparison to the fourth quarter of 2019, about 70% of worldwide working hours were lost in 2020, equating to 500 million full-time jobs. And working classes are especially significant in Latin America, the Caribbean, Southern Europe, and Asia. And consequently, the worldwide labor income was expected to decrease as well. Several research were conducted by the CG model to evaluate the impact of the COVID-19 on economic and social aspects. In 2020, Birur has all assessed the impact of the COVID-19 on poverty, food insecurity, and diet, accounting for the complex relationship between the crisis and the income and living costs of the household. They concluded that the increase in poverty will focus on South Asia and some countries in Africa. Moreover, the paper and comments examine the effect of the COVID-19 on international trade based on three different scenarios. The first one is the V-shaped recovery, U-shaped recovery, and L-shaped recovery. They projected that the GDP would decrease about 5% in 2020 in V-shape, about 9% in U-shape, and about 11% in L-shape scenario. CAPRO estimate the potential impact of COVID-19 on the United Kingdom economy, including the direct disease effect, preventing public action, and associated policy. Their results show that the COVID-19 alone would impose direct health-related economic burdens of about £40 billion, equivalent to 1.7% of GDP on the UK economy. And for trial with mitigation strategies, the total cost to the economy is about £300 billion, equivalent to 14% of GDP. Another study presents the formal analysis of the macroeconomic impact of the COVID-19 pandemic in the US, China, and the rest of the world. They projected that the net US GDP loss from the COVID-19, which ranged from 3.2 trillion US dollar to 4.8 trillion US dollar in 2-year periods for the on-trade scenario. And the US impact are estimated to be higher than those for China and the rest of the world in percentage terms. In addition to the impact of COVID-19 on the economies, there are some other studies assess the correlates of the GDP and COVID-19 vaccine. Basis error explore the associations between the GDP of various countries and the process of the COVID-19 vaccination. The result shows that there were the strong linear associations between per capita income and proportion of people vaccinated in country with population of 1 million or more. And this study aligns with the Nawara study, which concludes countries with high vaccination rate has higher GDPs per capita. So let's talk about the vaccine inequities. About 85% of the worldwide vaccine doses were administered in high and upper middle income countries, with 75% in only 10 countries, including the US, UK, Germany, and France. and only 11% of people in low-income nations have received at least one dose. While international entities like COVAX and other vaccine donation programs aim to invest the global vaccine asset, it is predicted that some countries and regions will not achieve significant level of vaccination into 2023. Globally, inequality in vaccine assets can be explained by the rich country accumulation of vaccine, resulting in the poorest countries suffering considerable damage from the pandemic due to the lack of the vaccine asset. So now let's move on to the objectives of our research. The research analyzed the economic-wide impact of the COVID-19 on the global economies, evaluates the effectiveness of the COVID-19 vaccination toward economic recovery, and address the vaccine inequity among the developing countries with high COVID-19 infection rate. To cope with these objectives, 4 scenarios are proposed. The first scenario is about the global impact of COVID-19 pandemic in 2020. The second scenario is global economic effect with actual vaccination rate in some country. The third scenario is about the increase in vaccination rate in 2021 on the global economy. Let's say 70% and 100% of population get vaccinated. And the final scenario is about a very active vaccination rates across developing and developing countries. This figure shows our modeling framework about the limitations of the COVID-19 vaccination scenario. The overall study approach includes the use of the models based on the COVID-19 infection rate and translate into the economic shock, health impact, disruption of the labor mobility due to restriction policy, and production in labor force participation, which are elements underlying in the social economic impact of COVID-19, are incorporated into the CG model to stimulate the impact on the development of economy, consumption, international trade, and welfare. And moreover, the health consequences of the pandemic on labor productivity and supply are associated with the result of the model. One of the important findings is the change in GDP across the vaccination scenario. Our model predicted that the increase in vaccination rate is associated with the increase in GDP. Change in real GDP range from 0.007 trillion US dollar for Vietnam to 0.5 trillion US dollar for the USA if 75% of the population get vaccinated. In case 100% of the population get vaccinated, this number would increase further. This can be explained that the increase in demand level and the rise in both consumption and purchasing have occurred as the economy has recovered since the travel restrictions were lifted. Moreover, vaccination has advanced work mobility since the labor force is back to work and they are currently working from home, which led to the overall growth in the size of the workforce and role in the productivity of that workforce. For balance of trade, the US, India, Russia, Canada, and Vietnam are predicted to suffer the trade deficit when the vaccination rate varies from 75% to 100%. The business in the country try to meet the demand for products by selling out their inventories. However, they are not increasing their overall output productions of the goods at the rate they have to grow to solve the supply chain problem. So they import more goods to meet that demand. And China is predicted to experience the trade surplus under 75% of vaccination rate. And next one is about the welfare. Welfare decrease significantly. The thanks to the vaccinations, the country in the model experienced a huge increase in the welfare because labor get back to work. Welfare increased by 1.0% in US, 2% in Vietnam, 1.1% in India, and about 1% in the EU. The country has high infection rate. Therefore, when people get vaccinated, welfare is affected positively. In the actual vaccination rate, the endorsement components dominates for the US, EU, Brazil, and Mexico. It can be explained that when the labor gets vaccinated, they are able to get back to work. Hence, the number of labor increased. And for the sectoral impact, our stimulation highlights the considerable expansion in the sector level production changes. More industry experience a noticeable boost in output due to the increase in vaccination rates across all the model region. When the vaccination rate hit higher level, people will be more comfortable returning to their normal life. And with the labor productivity gains across all the industry, and labor participation and productivity are projected to increase significantly with the higher vaccination rate. For this session focus on the vaccine inequity scenario, and we assume that about 70% of developing country population get vaccinated. The findings show there is an increase in GDP in those countries from 0.5% for Vietnam to 0.5% to Colombia. Relatively higher vaccination rate in some developing countries has shown an escalation in overall global economic recovery. As a result of increase in GDP, all countries get increase in sector level production chains. People are back to their normal life, so there are an increase in demand and supply side. In conclusion, the impact of COVID-19 on global economies were driven by the economic consequences of the reduced labor supply and productivity in various economies. Our results show that COVID-19 vaccine strongly affect economic activity. When the vaccination rate hit much higher level, people will be more comfortable returning to work, and labor participation and productivity will increase significantly with the higher vaccination rate. And the lower vaccination rate in some developing countries has shown a slowdown in the overall global economic recovery. Therefore, the need for the vaccine equity to control the pandemics require the collaborations of both developed and developing countries at the global scale. And this is a reference for my research. Thank you for listening.
Thank you, Trang. Now let's go ahead and get some questions from the audience. Yes, Geeta, I see your hand up. Go ahead, Geeta.
I was actually saying like clapping, not hands up.
Oh, that was a clap, sorry.
It was a great presentation, Trang.
Yeah, Mr. Henning, please go ahead. Oh, yeah, that was also clap. Okay. I thought
No, it is a hand up. I'm not sure whether I'm doing it the wrong way. Probably I am. Sorry about that. I was struggling because it continues to disappear also. So I think I'm doing it the wrong way. Anyway, thank you so much, Trang, for a very interesting presentation. My question is related to the epidemiological model, which is underlying your simulation. So I wondered if you could perhaps expand a little bit about which type of epidemiological model and which team, if you're collaborating with somebody, that would be of interest to me to know. Yeah, I forgot the other part of my question, so I'll leave it at that.
Trang, you want to take a crack at that first?
Okay.
Yeah.
So this is the modeling framework about the implication of the COVID-19 and vaccination scenario. So in this model, we focus on the reduction in the labor force participation due to the restriction policy and due to the infection rate. So description of the labor mobility and decrease in the labor productivity, and we combine with the vaccination rate, and and then after that we incorporate into the CG model to see how it's impact to the economic, global economic, and how the different vaccination rate can affect in the different level to the economic.
If I could add to Trang, to Mr. Henning's question, it's not any epidemiological model. We do not have any collaboration as such, but we are taking it from the literature, from basically what is the infection rates which is happening as a world chronometer. That's the actual infection rates which happens, and then how we translate into labor productivity shocks based on these studies. So that is the idea. But definitely that's a great offer. Like, you work on epidemiological models, so definitely it's a very good way to collaborate and merge these epidemiology plus the CG models. So definitely we were looking for somebody to collaborate at the time when they first started. So we didn't have anyone. So we just borrowed it from the literature and then estimated what would be the impact of this COVID. There was prior to this, there was a paper which Trang worked on that was related to COVID impact on tourism in Vietnam. And then now this is an extension, like, okay, now vaccine came. So what is the impact of the vaccinations at different rates? And if there is any vaccine inequity, about what they are discussing. So that's what we were trying to find out here. Thank you.
Yes, and of course I get that it makes sense also now that we are a couple of years into the pandemic, that we can look back and do retrospective analysis rather than prospective analysis.
Correct.
And also my question was also sort of focused on the fact that you're using a global model. So actually doing epidemiological models for modeling for all of these countries that you're focused on is an enormous task. So I was kind of curious, but thank you very much.
Thank you. Are there any other questions? Yes, Zhan.
Yeah, thank you for the presentation. I have another question. Is that on this slide you showed there's some exogenous shock from the COVID, mainly on the supply side. For example, the shock on the labor supplies and the labor productivity. I wonder, do you also consider some shocks on the demand side? For example, because of the COVID, the demand of the tourism will be going down for, I think, for everywhere in the world, or maybe because the transportation overseas, the price is higher, so people will also have a lower demand for the imported goods. I wonder if you also consider taking this demand level influence into your model or not.
Zhan, I missed the last part of your question. Is it what was that? Is it imported versus?
Yeah, the last part is that I wonder, because the COVID makes the overseas transportation be more expensive, so that people's demand on the imported goods will also be affected.
Okay.
Yeah.
So okay. So this is what happened during the COVID, immediate aftermath of COVID, right? What is the impact of the COVID? So here basically, the 2019 is the base year. 2019 to 2020 is the period which is the COVID impact, and post 2020, in the 2021, we saw all the vaccinations came in. So Trang, you want to explain like how 2019 to 2020 shocks were done as part of COVID impacts?
Okay, sure. From 2019 to 2020, we focus on the shock of the labor supply shock and also the labor productivity shock for 2019 to 2020. And after that, the vaccine comes, so we continue to stimulate the both 2020 to early 2021 for the economic, and we still focus on the labor supply and labor productivity.
So basically, there was capital and labor, both shocks there. So it's inefficiency in those sectors, and it impacts the demand, basically both domestic and imported goods. So that translates into GDP impacts. That's what was happening in the COVID scenario case. And it doesn't explicitly include anything like, okay, there was a lockdown, there was no transportation at all. But because it's the inefficiency in the labor supply and capital in the economy, in the entire global economy, depending on different countries' infection rates. So transportation is also a sector which gets impacted for all the sectors, and that translates into overall GDP impacts.
Okay, thank you very much.
Any further questions? If not, thank you, Trang. Let's all give Trang a round of applause. Our next presenter is Mr. Henning Tarp Jensen. He is from London School of Hygiene and Tropical Medicine, London, United Kingdom. So he will be presenting on international trade, dietary change, and TB control in India, application of a fully integrated macroeconomic epidemiological model framework. When you're ready, Mr. Henning, the floor is yours.
Yes, thank you. I'm just going to try to see if I can
share.
Does this work? Can you see the screen?
It's starting. Yes, we can see it.
Great. I will get it back to the start. And I hope it will soon come. It doesn't seem to work. I'm trying to get it to do the presentation.
Do you have the F4 or F5 button?
Okay.
Yeah, you have it at the bottom, like a slide show.
Oh, I have. Okay, I'm just seeing the full screen myself. Okay, brilliant. Thank you. Sorry about that. So let me start. Oh
no, you're sharing other screen, I think. Do you have two screens?
I'm sharing a desk screen.
Okay. You are on slideshow. Are you on slideshow right now?
No, I'm not. I'm trying to be,
okay.
But it doesn't seem to work.
Yeah, at the bottom, it's not working. Is it not working?
No, it's not. I'm pushing this button, basically the farthest to the right on the bottom, which is the slideshow, but it doesn't seem to come
we
on.
had the same issue with Ghada too. So she converted it to a PDF file and then opened it.
Ah, okay. But are you able to see my screen?
Yeah, we are able to see. I think we should be fine.
Okay.
But if you notice the full screen on our side, we can see the other slide and also the note part. So it is not a full screen.
No, it's not a full screen. I understand that, but I'm not able to get it to full screen.
So how about we save that as a PDF file and then open the PDF file as a full screen?
Okay. Really?
Yeah,
I mean,
I think we are fine with this one. We are able to see this slide. Yeah.
Yeah. Okay. I'll continue then. Okay.
Yeah,
brilliant.
thank you.
Thank you. Okay. So thank you so much for inviting me to present. My presentation is the title is International Trade, Dietary Change, and TB Control in India: Application of a Fully Integrated Macroeconomic Epidemiological Model Framework. And we could have added the demographic also. So it's essentially a macroeconomic, epidemiological, and demographic model framework that we are constructing. The scope of the study is to do a holistic trade policy analysis of TB in India. So the simulation scenario and simulation period the country is India. The time horizon is 2021 to 2040, and the policy scenario is import tariff elimination. And of course, it's a standard trade policy, but in this case, we're trying to do a new thing, basically adding, in addition to analyzing the efficiency gains from trade liberalization, we are adding the health pathway, which is via nutritional risk factor, low BMI risk factor of TB, essentially, which are affected by trade policy, trade liberalization, and which will then affect TB outcomes. It can both be positive. You can hypothesize whether it can be positive. It can lower some imported food prices, but it can also be negative because it might create this real exchange rate depreciation, which may increase some domestic food prices, and so it can go either way. So this is what we are analyzing. Now, our framework consists of a macroeconomic part, a health part, and a demographic part. And I've tried in the bottom here to sort of also in different colors show how they link together, these different parts. So the inputs and outputs, they're just the parts which sort of makes the framework fully integrated. So first of all, the macroeconomics. We're using a dynamically recursive computable general equilibrium model in annual time steps. The inputs in terms of model integration is TB-related clinical outcome impacts, which comes from the demographics down below the green color. And the outputs in terms of model integration is low BMI prevalence rates, which essentially comes from demand systems in the CG model. I'll go into more detail about how we actually go about producing, measuring this. Then the health model is a compartmental dynamic model of TB transmission. It is specified with bi-weekly time steps, and it's specified for each of our 5 households, income quintile households. There's a lot of time steps here, considering it's 2021 to 2040, but it's stable, and we haven't experienced any problems in terms of computational issues. The inputs of the health model is the low BMI prevalence rates from the CG model, and the outputs in terms of model integration is TB-related clinical outcome rate impacts, which is then transferred to the demographic model. The important thing here is the rate, because our health model, our TB transmission model, is basically specified for each of the 5 income quintile households, specified with a population of 1. So you will see the compartments. Basically, what we are measuring is the shares of population in each compartment. That's what the TB model does. And then we basically take those rates, the clinical outcome rates in terms of morbidity and mortality, and impose them on a demographic model, which is run simultaneously, and then compute based on these demographics and these clinical outcomes. We can then compute the mortality and the reductions in labor force, both due to morbidity and mortality, but also the government health expenditure changes due to changes in morbidity and incident cases. Now, to give some background, TB global context, we have first of all, TB is mentioned in the Sustainable Development Goals 3.3, should be eliminated ended by 2030. There is the WHO End TB strategy, which was developed around the same time as the Sustainable Development Goals. It has 2020 milestones here. So TB incidence rate, annual TB deaths, households affected by catastrophic costs. As you will see, basically none of them are fulfilled. So we are quite far away from these milestones, the WHO milestones. There's a lot of discussion in the most recent global TB report about COVID and how that has affected. But if you go back 1 year, they were still not on track even in 2019. So there is an additional sort of lag in terms of country-specific policies. And then there is one more thing which sort of has added momentum to the fight against TB, which is the UN high-level meeting, the first UN high-level meeting was convened in 2018, and they undertook a strategy for 2018 to 2023. Every 2 years, there is progress reports on these additional targets, and another progress report will come in the end of 2022, and the second high-level meeting will then be coming in 2023. So there's political momentum being gained in this area. This is what you should take from this, even though the targets are still not being met. Now, India context in terms of TB, the top table gives you some numbers. The important thing to take from that table is basically the share of global numbers. So the top row is total TB incidence, and you can see that India accounts for 44% of total TB incidence, and the third row says 38%. India accounts for 38% of HIV-negative TB mortality. So India is really, it's accounting for a huge share of TB globally. Now, the bottom figure basically shows deaths from TB. The blue one is excluding HIV. The red one includes all forms. And you can see that they basically converge, which basically is it resembles that, or it tells you the story that India has basically managed to get control of the HIV, their local HIV epidemic. And so HIV is no longer a big risk factor in terms of TB, because most HIV patients are being treated. And then the final thing you can see here is that little tick up from 2019 to 2020, which is the COVID-19. And actually, you can also see it's a slow process to actually get control of TB. And then COVID-19 comes and it erodes essentially what is 7-8 years of gains, basically. We will see how it fares the coming years, but it is a big setback, the COVID-19 pandemic for TB sort of control in India. Okay, so now that was the background and motivation for why we actually need to look at this. So the integrated macroeconomic health demographic framework. I actually have some nice slides. I cannot show it because some animations, because it's not working. but anyway, it'll also save me time. So it's just the CG model and how it sort of links together with our nutritional module and the risk factors, how it feeds into the TB transmission model, the clinical health outcomes, which then feeds into the demographic model, and we then, based on demographic outcomes, we then can compute health costs, changes in health costs, and changes in health and demographic impacts, which affects the labor force and the production in the economy. So this is the feedback loop, essentially, which makes it fully integrated. And the key thing here to note is the risk factor, the endogenous risk factor, which is the low BMI up here. Okay, and this basically sort of illustrates further the feedback mechanism. I'll speak more about it in a little while. Okay, so very quickly, I'll run through the data that we've used. 2014 social accounting matrix for India, GTAP 10 database. We aggregated 65 activities commodities to 31. We kept 11 primary activities commodities and 11 secondary, including 7 processed food sectors. So we basically aggregated most of the non-food sectors to a more manageable size in order to allow the model to be computationally more feasible in terms of the integration. Then we aggregated the 5 production factors to 3. We maintained the 2 labor types, unskilled and skilled, but we aggregated the remaining land, capital, and natural resources into 1 capital factor. And then we broke out 5 representative households according to income quintiles, and it was based on the 68th National Sample Survey 2011-12 for India. The structure of the Indian economy is presented here, and I won't go into detail, so don't worry, but just highlight that there is this vegetable, just for the sake of argument, vegetable oils and fats here. You can see the first column is the import tariffs. There is an effective import tariff of 48%. The last column is the import share of this sector in the economy, which is 20%. So you have a combination of a very high import share, an important processed commodity, food commodity in the Indian economy. You have very high import share and you have a very high tariff. So of course, a trade policy analysis, you would expect that reducing the tariff, this might lower the price of some of these commodities, which can actually give poor people and people in general in India sort of a boost in terms of nutritional intakes. And this can then sort of improve their BMI and reduce the risk of getting TB. So you can see this is sort of an indication that it was reasonable to assume that there would be positive health outcomes coming from trade liberalization. As you will see, actually, the result is opposite, but we'll get back to that. The CGA model is dynamically recursive, so just giving you the heads up on the data underlying the updating the factor updating equations, the capital factor updating equation. We took for 2014 capital stock depreciation rate from the Penworld tables, and we broke out the capital ownership across households based on the 68th national sample survey for India. The labor factor updating equations, we derived age-specific labor force participation rates from the periodic labor force survey of India, 1920, and then the labor force factor stocks from 2014. We based that on the World Population Prospects demographic projections from the UN, and then we disaggregated across our 5 income quintile households based on this national sample survey again, and then we applied these age-specific labor force participation rates to arrive at the ownership, labor factor ownership by household. Okay, an important part of our model framework is demand, of course, because it's the nutritional pathway to the risk factor for TB, which is we're modeling. So basically, we specified 8 demand systems for each of our 5 household types. We used this data from the International Comparison Program data program, and we combined it with some food price elasticities more recent from Tamil Nadu, and then we derived raw matrices of 8 demand system parameters. Of course, they didn't satisfy the raw matrices, never satisfy the regularity conditions which are required for these demand systems. So we used the cross minimum entropy methods to balance all of these 5 demand system parameter matrices. Now, in terms of nutritional intake and body weight, the data we took from the metric food consumption data, which is needed in order to actually be able to measure these kilocalorie changes, we took from FAO food budgets, 2013 food budgets, and kilocalorie nutritional coefficients, which we are going to use to apply, which we apply to the demand for each of the households' food consumption. We took those from the USDA data set. And then the formula which translates the kilocalorie intakes into changes in weight, we took that from Scheelbeck et al. 2019. So basically, you have to divide by this number 7,715 in order to get the change in kilograms. Actually, it should say kilograms, but that's the formula. Now, in terms of the risk factor for TB is actually the prevalence of TB. So in order to measure the prevalence within each of the 5 household types, we need the distributions of the weight, and then we need to basically find a way to allocate the changes in weight, the average weight across these intra-household distributions. So basically, we got intra-household distributions of weight, height, and BMI from the National Family Household Survey 2019 to 21. And then what we do is basically when we model, we switch the entire distribution by the mean, essentially. And then we compute how many are below the low BMI boundary, which is 18.5, essentially. And then we can come up with the change in prevalence, which then conditions changes in TB. Okay, the demographic model type, I'll just skip over this, but it's population-based. It's not a cohort, but it's population-based. So there's also births in this model. Now, moving to the epidemiological model, we have 5 compartments: susceptible, latent, infectious, treatment, and death. They are linked in this way. So basically, from susceptible state at the left hand, you can progress either to the latent state L or directly to the infectious state I. From the latent state, you can also move to the infectious state either through reactivation of the infection you already have, or from a reinfection. Or you can, and then from the infectious state, you can, from natural recovery, move back to the latent state. You can be diagnosed and move to the treatment state, or you can die. And from the treatment state, you can have either successful or failed treatment, and depending on that, you move either to the latent state or to the infectious state. And we have dynamic equation systems to capture these links. Now, the important thing here is the two red boxes. Those are the two key parameters which our risk factors, and in particular our nutritional low BMI risk factor, can affect. It's the transition from the susceptible state through rapid progression to the infectious state, or from the latent state to the infectious state. Those are called the A and C parameters. They're on the next slide. And basically they are determined in the model. These are the two parameters in the model which are affected by the relative risk of TB. And this relative risk for each household we computed as the prevalence of risk factor of each of these 6 risk factors times the relative risk associated with each of these 6 risk factors. And that gives you an overall relative risk for each household, and that determines the size of these two parameters. The rest of the parameters are constant across the different household types and the TB models for each household type. Here are the 6 risk factors again. Again, low BMI is the key one here because it's endogenous. And here are the parameters, and you will see the A and the C parameters here. They are indexed with H because they are varying with the household type, and they are actually endogenous because they depend on the relative risk of TB. So, and basically they are computed in this way. They're computed from a set of prevalence rates, this matrix, and from the relative risks associated with each of the 6 risk factors. And then that gives you the overall relative risk of TB for each of these households. And you'll see the low income quintile household has a relative risk of 2.0, which is much higher than the high income quintile, which has a relative risk of 1.24.
2 minutes left.
Yes, thank you. One more thing on the specification. We also allow for mixing between the different household types, and we use the 26th time step of these bi-weekly model simulations as the annual solution. And we also, okay, results. So I will quickly move here. The important thing to note here is that there is overall efficiency gains of more than $100 billion over this time period, 2021 to 2040. This covers efficiency gains actually of 119, but then losses due to health of $15 billion. So there's a trade-off here, which is already showing up in the computation of these gains from trade liberalization. Now, and this is just to say that actually investment is going down. This is due to a real exchange rate depreciation, which makes investment goods more expensive. Sorry, I punched the wrong button. There we go. Okay, this slide shows you something about the household distribution of the impact on household income across the different household types. And essentially, it is saying that everybody is gaining roughly the same percentage, and it's dominated by the gains from trade liberalization. The health costs are not very big compared to the gains from trade liberalization. But the next set of slides then shows you the trade-off, which is down here, the clinical outcomes. Basically, the TB incident cases and case fatalities for the low-income household, all of them increase. So the case fatalities increase between 10 and 18%. The incident cases increase between 11 and 20%. The low-income households, they have much worse health outcomes, 18 to 20% increases in incident cases and case fatalities. compared to the high income, which only has increases of 10 to 11%. So basically, everybody is gaining from trade liberalization, but everybody is also losing out from worsening clinical health outcomes, basically. Okay, so conclusions. The net present value of GDP efficiency gains from trade liberalization are substantial, around 0.15% of NPV GDP over the next 20 years. But health matters in Indian health matters in Indian trade policy. So the nutritional TB risk factor is potentially very important health pathway in India, and it could reduce efficiency gains by 1/8 or $15 billion. All households benefit economically from trade liberalization, but health outcomes worsen, and they are the worst for the lowest income quintiles. So TB clinical outcome worsens strongly for the low income, 18 to 20% increases in case fatalities incident cases, and less so for the fifth income quintile, 10 to 11%. So the conclusion is that trade liberalization may worsen health outcomes and health inequalities, even though there's a lot of economic gain to be had. And so Indian policymakers should undertake comprehensive economic and health policy studies before embarking on trade liberalization. Thank you. Should I stop sharing?
We would love to see those animations.
Yes, yes. Okay.
Thank you so much, Mr. Henning. It's a great presentation. So we missed all that animation. It's a lot of work, definitely. So it's very interesting, very relevant to the epidemic and all. So anybody has any questions for Mr. Henning? If not, can I ask, is these epidemiological models, can we, with the same type of format, what you are translating the TB incidence into the CG model, can this be easily adapted to any diseases, any pandemic, or just in general, any diseases, and by age group or something, is it possible?
Yes, it is, and actually, this is the research agenda that we're pursuing. So I should say that I'm not doing this on my own. I mean, I'm the expert modeler, but I'm closely collaborating with Marcus Q. Brown, who is also an associate professor at LSHTM, and our team, we collaborate with different teams on different types of illness. So we've previously worked on malaria, where we created a fully integrated model with epidemiological models of malaria transmission, and we've also in Thailand we've studied other types of nutritional pathways, which wasn't linked to infectious disease as in this case, but where it was focused on palm oil and cholesterol sort of intakes, and how this may condition health outcomes in Thailand, and that was also a fully integrated model framework. So there is a range of opportunities for application of this general sort of approach. The trick is, of course, to figure out where do we have epidemiological models which are suitable, because it's fairly easy to say how the feedback from the epidemiological model to the economy is. I mean, we can always, if you have an epidemiological model, you can always take the clinical outcomes and translate them into impacts on government expenditures and on the labor market. The trick is to figure out how to model the socioeconomic feedback mechanisms to the epidemiological model. Yes. That's the trick, and this is where all the hard work actually is. And in this case, of course, it amounted to all of this work on setting up this module for feedback to the through low BMI as a risk factor for TB to then model that. But it is definitely feasible for many illnesses. I mean, I've been arguing for quite a while now. It may no longer be the case, but I still need to be convinced about COVID that we still don't have quite a good handle about the feedback mechanisms from the socioeconomic sort of determinants on the COVID models, and especially the contact matrices, which are typically at the core of the COVID models. I mean, I think there are some data which is coming along, but we still don't have quite a good handle. So I don't see that we can do a fully integrated model framework, at least right now, but maybe in the not too distant future.
Okay. On that note, Mr. Henning, I was wondering, like, for example, if we consider the COVID impact itself, the impacts, the mortality rates were pretty high in the beginning in some areas versus some countries they were able to control. But it was the disease was same. They were saying variants were different and all. So, is there in your type of epidemiological model, is there a way to estimate like what would be the likelihood of like mortality rates and morbidity rates of a same type of diseases?
Say that again. Estimate the.
Globally, if you consider the mortality rates of COVID, they were varying. Like in the New York, New Jersey area, or Italy, for example, they have very high death rates compared to other countries. They were able to control it. So but the disease was same. Of course, the variant, they were saying different variant had different type of impact. In your models, for any given disease, can we have that heterogeneity in terms of impacts across geography? And you were also saying like geography matters, like how do we reconcile it for the entire globe if you want to do some analysis? That's where I'm getting at.
Yes. No, for sure. So first of all, if we took TB, there is that, as you saw, all of the risk factors, the prevalence of the risk factors, it varies from country to country. It would be a completely different picture if you took another country different from India. So there would definitely, I mean, you would have a completely different sort of dynamic in terms of the epidemiological model. In terms of COVID, there is, I think, I mean, one thing which has marred the epidemiologists so far is also the contact matrices. They've used some old contact matrices, which the roots of which you could discuss, and of course you only get as good an output as the input allows you, and so in that respect, but otherwise the epidemiological models, they do depend on the contact matrices, and to the extent that they vary across countries, you will also get heterogeneity in terms of outcomes, and then of course, I mean, if you like one of my esteemed colleagues mentioned before, if you go and look at sort of the demand side of these sort of reactions in the economies to the COVID pandemic, you can also start to think about, well, if differences between countries, if you have a country where for some reason the culture it doesn't allow, or where the public won't change their behavior, while in other countries you might have some cultural institutions or maybe other institutions which sort of are able to communicate to the population and allow for changes in behavior and contact patterns, which are not, that may condition how much you need to go into actually lockdowns, which are very costly, of course. And so that type of modeling, I think, is also very important. The trick about the demand, of course, is that it's so essential for our CG models. It's very difficult to start to mess with the demand systems. I'll stop here. Thank you.
Thank you so much, Dr. Henning. So that actually, please let's give Dr. Henning a round of applause. So this wraps up our final presentation and discussion period for this session. Oh, anybody had any other questions? No, right? I didn't hear. That was black. Okay. So please help me thanking our presenters for these valuable and thought-provoking presentations. I definitely learned. I would have definitely seen that visuals, because that's very, very nice to see for us modelers how the graphics work, automations work. And we appreciate everyone joining and hope you enjoy the remainder of the conference. Thank you.